Thank you, everyone. Thanks for having me here today. Can everyone hear me in the back of the room? Okay, raise your hand if you can. Okay, looks like it's okay then. All right, well, thank you guys for having me. I'm Ms. Jenny Moore. I am a physical therapist, and I have been working for many years on helping hospitals and clinics use more standardized measures in clinical practice and also help them evidence-based interventions. So my specialty areas are really is what I'm talking about today. First of all, I'd like to thank Lena Emelson, who invited me to present today. I'm grateful to be here, and I think it's a really cool experience to be a presence. Hopefully you guys can all hear me okay and we don't out. I would like to try to do this in an interactive way, so I have some questions for you guys during the presentation as well. To thank Michael Nilsson, who really important information about standard practices related to measurement in Sweden, so that I could better tailor my presentation and as a result of put together a better presentation for you guys. Okay, so a quick question. I had a few interruptions on my side. Are you guys still hearing me okay? And it's okay, it's fluid, great. I'm gonna move a little bit closer to you. This is a really cool device. Have you guys seen this before? Yeah, it's the first time that I've done it. I promise I won't get too close. There we go. Okay, so I'm going to be talking about measurement and knowledge translation today. It's a lot to cover, and I'm really going to just cover at a very and hopefully simulate a little interest in both of these areas. So go ahead and go on to the next slide, please. The objectives of this presentation are to, or hopefully at the end of this presentation, you should be able to describe the importance of using standardized measures to assess patients undergoing rehabilitation. You should also be able to define translation, and lastly, identify the link between measurement and knowledge translation. And I'm curious to know how much about this you guys already know. So my first question is, how many of you are already feel? All right, sorry. How many of you could feel like you could already describe the importance of using standardized measures to assess patients undergoing rehabilitation? Raise your hand. Okay, we got a couple of people. How many of you are familiar with the concept of knowledge translation and could define it? Raise your hand. Okay, all right, so then thank you for that. That helps me a lot. I also have a few more questions for you. What is your clinical background? How many of you guys are clinicians? Raise your hand if you're a clinician. Great. Raise your hand if you're an administrator in a healthcare organization or another kind of organization. Okay, good. We have a few people. How many of you are researchers? Great. And are there any other groups in the room?
Patients.
Patients. How many of you are patients? Are rehabilitating? I see a few. Any? Great. Any others? No? Okay. And I'm assuming some vendors as well. I saw some vendors out in the hallway. Did I hear something? Okay. All right, next question is, do you or your facility use standardized measures in clinical practice? Now, standardized measure is a measure that's been tested for reliability and validity, and it often has information to support clinical decision making. So it can help us identify fall risks, sorry, all right, I'm back. Other people are functioning with patients, and they can also provide information to help us understand whether patients are provided. So how many of you guys use standardized measures in clinical practice? Or for those of you that are patients, how many of you remember being assessed with some sort of a standardized measure? if you could just say into the microphone what people say. Can you tell me what measures you guys are using in practice?
Sorry, what is MMRs?
What did you say?
MMRs, measure, what's it called? Yeah, motor assessment scale. Motor assessment scale.
Sorry.
Motor
Please repeat it
assessment
for-
scales.
What did you say?
Motor assessment scales.
Motor assessment scale. Perfect. Thank you. Any others?
The people working in the clinic, what measurements are you working with?
Bergs balanstest till exempel.
Boys eller Bergs balanstest.
The balance test, voice,
Which one?
voice.
Balance test? A balance test?
Berg's balance test, yes.
Berg balance test. That's probably the most commonly used balance test in our field. I hear that one quite often. Any other?
Ashworth specific scale.
Sorry, I'm going to move on to the next question real quickly, and then I'll go on to my presentation. Are there any specific questions that you hope that I answer today? We have a short period of time, so if you have any specific information that you really hope that I provide, I would love to hear it, and I'll make sure that I integrate it if I can. And if not, that's okay. Okay, I see no hands. Well, feel free to interrupt anytime, and I would love to hear questions that you guys have. Okay, so go on to the next slide, please. And the slide heading should say, why is measurement important? I became quite interested in measurement when I was working on my doctorate of health science, because at that time I was working part-time in a research laboratory, and I was working part-time in a clinical practice setting. And what I was recognizing was that patients were being referred to a research project when clinicians were telling me that they had plateaued in therapy and they were no longer benefiting from services. And so they would come in and start a research study, and regardless of which group they got in, whether it was a conventional therapy group where they received a therapy that was similar to what was provided in the clinic, or if they received an evidence-based they appeared to benefit from the program. So I became quite interested in that idea that the clinicians felt like the patients were improving or were plateauing. They were no longer demonstrating improvements in their function, but yet they still had the capacity to improve. So I decided to do my dissertation on that. I go on to the next slide, please. I started recruiting patients while they were undergoing rehabilitation. And I was bringing them into the laboratory and doing standardized measures to monitor their changes during their care, but I wasn't sharing that information back with the rehabilitation provider. When the rehabilitation provider told me that they were about ready to be discharged because of the reason of a plateau, or basically that they were no longer improving in function or benefiting from therapy, then I would measure them again, and then they would come and do an evidence-based rehabilitation program with me. And basically what I found was very, very surprising. If you look at the figure here, you can see data points A1 and A2. And those are the clinical data points. So when the patient came into the research laboratory and I assessed them using a standardized measurement, what I found was between these two data points, patients were actually making substantial improvements. So they weren't actually plateauing at all. So go on to the next slide, please. Okay, so this slide shows a table of the results. And you can see self-selected velocity and fast velocity, which represents gait speed. And then the 12-minute walk test, which is a walking distance test. How far can people walk over 12 minutes? And basically what we found was that patients were making statistically significant changes during this time period, and they had huge effect sizes. So the effects had really, really great magnitude. And then when we looked at the literature on information to help us interpret these results, such as standard error of measurement, which helps with measurement error isn't a tool, and other kinds of information like minimum detectable change and minimum clinical important differences that help us understand whether the changes were meaningful, we found that the changes exceeded measurement error. They weren't, but they exceeded measurement error. So it's quite possible that these patients were still changing and they still had the capacity to change more. So I wanted to better understand that. I dove into the research to see if this has been studied, and I also dove into the patients during therapy. And what I found was that in research, that in semi-structured interviews, qualitative studies, there was evidence to suggest that clinicians were often using and perceptions of whether patients were changing to monitor progress and rehabilitation. And when I looked in the charts of these patients who went through my study, I found that only 10% of the patients had a standardized measure collected on them. And all of the progress was being monitored by clinical experience. And so this data indicates this can lead to inaccurate identification and an early discharge in therapy, and it can also prevent achievement of maximal patient outcomes, because these patients then came into my study, received evidence-based rehabilitation, and they continued to demonstrate improvements. So that was really my aha moment of we've really got to get more information out there about standardized measures and why we should be routinely using these kinds of measures to monitor progress in our patients. And so after that, I started on an initiative to put information together for rehabilitation. Have you guys heard of the Rehabilitation Measures Database? If you have, raise your hand. No, a few of you guys have? Okay, so if you haven't, I highly suggest going to this website. This is a website that I started with some colleagues at the Rehabilitation Institute of Chicago, which is now called the Shirley Ryan Ability Lab. And it has over 400 instruments in it, and it describes how to use them, how to interpret the results, and information that's really important for clinicians to make decisions on this data. So, from around, it really is a great resource to go to. All right, go on to the next slide, please. So the title slide should be called Measurement Purposes. Is the correct slide up on the screen? Okay, good. All right. So now over the next few slides, I just kind of want to provide some basic information about methods and why they're important in practice and different ways that they can support our clinical decision making. I'm going to talk about 4 types of measures, and then I'm going to give you some practical examples of how these measures can be used. The first one is that measures can help us screen for possible problems. As we know in the research practice, we can see that when patients are depressed, they often have poorer outcomes. They're not able to engage as much in rehabilitation. A screening tool for depression will help us understand and identify the presence of possible problems. So screening tools do exactly that. They provide a general assessment to help us identify that there might be a problem, and then they can help us refer people to the appropriate provider to ensure that problem is dealt with. The next thing measurements can do is help us discriminate among impairments. So I have an example of that related to balance. Balance can be made up of anticipatory postural control, which are the kinds of activities that we can anticipate that we need to shift our balance for. Reactive postural control, which is being able to recover after a fall happens or is induced, and so you don't land on the ground. It is also sensory orientation, so different vision and vestibular that might impact our ability to stay upright. and it's also dynamic gait, so how we're able to maintain upright while we walk. There is a measure, which I'll talk about in a minute, that helps us understand where the impairments and balance are. So by doing the assessments, we can say, okay, this person's primary problem is in this particular area of balance, and we should target the area of balance during treatment. And that's an example. Another way that measurements can help us is to identify change over time. By using measurement information, we can understand whether two data points are within measurement error of each other, so we can be confident that the patient did not change as a result of the therapy provided, or we can understand whether therapy had a meaningful impact on a specific function. And lastly, measures can help us predict future events, such as falls or walking capacity, or perhaps even discharge location from an inpatient type of a study. Okay, so I have a couple of practical examples of that. The first one is a screening tool for depression, the PHQ-9. Are you guys familiar with that screening tool? Have you guys heard of that before? Raise your hand if you have. Okay, I think I see one hand up. That's good. It's a self-report measure. Right, go on to the next slide. It says measurements, practical examples, depression over the top of it. So the self-report measure that identifies the presence and symptoms on it that are scored 0. So a maximum score, which would be, a 3 on every single item, would be a 27. A 0 on every item would result in a minimum score of 0. So a score greater than 6 indicates a major depressive disorder. So I'm just going to give you an example. Let's say that at your clinic or your inpatient hospital, you've decided to routinely administer the PHQ-9 at admission. And a patient scores that you haven't even evaluated yet, the patient scores a 9 out of 27 on that particular test. What does it tell you about that patient? If they get a 9 out of 27 on the test. Anyone want to shout it out? So a score greater than 6 indicates a major depressive disorder. The admin assistant hands out the form, the patient fills it out, you get it before you, and you see the score is a 9 out of. How many of you guys think this patient might be at risk for depression and would need to see a psychologist? Raise your hand if that's okay. So in the patient, you have this information because this PHQ-9 was taken, and it's something that you should consider during the evaluation, and maybe even the timing of the therapy. This might be something that might need to be addressed before your therapy could really be effective. All right. Go on to the next slide. I have a measurements example of balance on it. On this slide, I'm describing the mini best test, which includes a 14 between the 4 balance areas that I was talking about earlier. So the maximum score on the mini best test is a 28. So let's assume that you do the mini best test on a patient and the patient scores an 18 out of 28 on the see that the person achieved a maximum score of 6 out of 6 on anticipatory postural control, 1 out of 6 on reactive postural control, and a 5 out of 6 on sensory orientation, and a 6 out of 10 on. Just by looking at the and there are 2 particular areas of balance that might need to be targeted during your therapy, and that's the reactive balance and the dynamic gait sections. So very quickly you can hone in on the problems that you could target. Okay, go on to the next slide, please. All right, I'm going to go on and talk a little bit more about the mini best test and give a couple of examples of prediction and change over time. We also know that with the mini best test, depending on the study and depending on the patient population, we know that it could potentially predict fall risk. And in general, a score of 19 or less may indicate a patient is at fall risk on this scale. We also know that it has a potential to assess change over time. So we know that a measurement error within the tool is about a point. So it ranges from 0.86 to 1.26 depending on the study, but it's around a point. So if we have a patient from a 19 to a 20, the patient improved on the scale, but it was still within error. So we can't be confident that the patient made a meaningful change, okay? But we do also know that scores should change on average 3 to 6 points to know that the patient made a meaningful change as a result of your therapy, that a meaningful improvement that has impacted their life in some cases. So, and I say 3 to 6 because this varies based on patient population and the studies that the information was provided in. So now we have information that helps us with this one test, discriminate among balance impairments, predict whether a patient might be at risk for falls, and helps us understand whether an impact on their function. So in this example, again, the initial score on the mini best test was an 18 out of 28. The interim score went to 20, which is the middle score during the patient's episode of care. And then, so was the patient at fall risk at admission? Raise your hand if the patient was at fall risk at admission. All right, try it again. Raise your hand if the patient's at fall risk at admission, if you think the patient was. Yes, you're right. So it was scored less than a 19. At discharge, was the patient at fall risk? No. Did the patient make a meaningful change as a result of therapy? Raise your hand if you can be confident that the patient made a meaningful change as a result of your therapy. So it's very, very important information these measures can provide us. So great job. I'm going to skip this slide because we're running a little bit late in the presentation. So I'm going to go on to the concept of knowledge translation. Implementing evidence into clinical practice is very complex. The last slide I was going to ask you about barriers to using outcomes. I bet many of you guys could raise your hand and list at least 10 problems that would make it difficult to use measures routinely in clinical practice. It is a field of study that attempts to help us systematically identify and address those barriers to more quickly implement evidence into clinical practice. The definition of knowledge translation is listed here on the slide. It's a dynamic and iterative process that indicates the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health and products and strengthen the healthcare system. So a couple things that are important. It's a process. So there are multiple phases and multiple people that have to be involved. It includes the synthesis of information, so it represents implementation of a large body of evidence and not just one study. And it's the actual use of the evidence in clinical practice. Now this field of study, go on to the next slide. It should say the knowledge to action cycle on top of it. This field of study and actual knowledge translation practice is called frameworks to help us systematically implement evidence into clinical practice. The one that I have on this slide is the knowledge to action cycle, which was developed by Ian Graham and his Jakes. We don't have time to talk about it, but just note, in most knowledge translation frameworks, there is an attempt to identify and systematically overcome barriers. Use evidence-based knowledge translation strategies, which are strategies to more quickly implement evidence and influence more adoption. And then also evaluate the impact of practice at the patient, the provider, and the organizational level, which I'll talk about in just a minute. And then, of course, if there was a behavior change in practice, we need to make that a sustainable change in practice. So go on to the next slide, please. I'm going to talk a little bit about the evaluation of the impact of the practice. As I said, it should be done at a patient level, at a provider level, meaning the clinician, and at an organizational level. And I'm going to hone in on the patient level. The best way to understand the end practice on a patient is through the use of standardized outcome measures. And it's important to systematically implement the new practice. So first, implemented standardized outcome measures to understand the outcome of conventional care. And then secondly, systematically implement the new practice so we understand the outcome of care with the new practice in place. So I have a couple of quick examples and then we'll wrap up. Go on to the next slide, please. Example 1, this is a comparison to historical data. If you look at the black line on the bottom of this figure, you could see, this is hypothetical, but you can see that if you had a standardized set of measures that you used to options, you would have a general like during care, physical therapy or occupational therapy, speech therapy, etc., that you provide. Once you have a large set of data, you have the practice, the data that you collect after implementing. In the example, you have a conventional, the line in black represents outcomes with conventional therapy. The line in green might show the comparison data for a new innovative intervention. So you can see in this case, the innovative intervention showed better outcomes. Another way to do it, if you go on to the next slide, is to do it as a single subject design. You have standardized measures that you implement with a particular patient. You do what you would typically do with the patient, you measure again, and then you do the new innovative intervention to see if the line changes, the slope changes, so the patient gets better outcomes as a result of that particular innovation. And then you can go back to routine intervention to see whether you have an effect for that particular intervention for a particular patient. And if you get effects like this over and over again, you're building a case for why that particular practice should be a routine practice. Okay, so I'm going to go on to the next slide. The objectives again were to describe the importance of using measures to assess patients undergoing rehabilitation. Did I convince you guys of that? Raise your hand if I convinced you at least a little bit that you might want to consider using standardized outcome measures in practice. Good. I know we very quickly touched on knowledge translation, but you have a slightly better idea of what knowledge translation is. At least you've heard the term before, right? And the measurement and knowledge translation. How many of you guys understand why measurement of patients standardized for knowledge translation to occur? Raise your hand if you have a better understanding of that. Good. All right, and I'm going to go on to the last page of questions. I think we're close to out of time, Lena, is that correct?